our final speaker, who is Jamie Kitt, to talk. Jamie's a consultant cardiologist working in Oxford, and with special interests and research expertise in cardiac imaging and obstetric cardiology. He's going to give us a presentation of the impact of a real-world postpartum in pregnancy clinic, something we've talked about already today, and he's going to explain how that actually works. Reflections of 12 months of research transition into clinical practice. Thank you, Jamie.
Thanks, Jimmy. Can you hear me okay?
I can hear you fine.
Thank you. It's been a bit of a mad rush. I've just come straight from postpartum clinic, in fact. So yeah, I did miss a couple of the talks. I'm hoping not to reiterate things that have already been said, but equally some of the stuff we're covering, I think, is worth repeating. It obviously has been a strong postpartum theme to today. But I think some of the themes that Lucy talked about in her keynote speech are also hopefully echoed in this in terms of the potential for, delivering on those big bets she discussed. I was funded by the BHF for my research, which encompassed the POP-HT trial that's been talked about earlier today. Due disclosure is that Paul, who is my supervisor, has some patents related, nothing to do with this. So I'm going to start by just discussing a case really of someone that we saw in probably the first clinic, which started last February. So she was 33-year-old, classed as a low-risk pregnancy, had been under midwife-led care throughout and had a normal 20-week ultrasound and was put onto a low-risk pathway based on her bloods. She unfortunately presented just over 27 weeks with severe hypertension and proteinuria, i.e. pre-eclampsia, and she got admitted to the John Radcliffe, and she was an inpatient on level 6 for the next 2 weeks with daily up titration of antihypertensives, but ultimately had to be delivered due to a sort of evolving health scenario. Postpartum, she had very labile blood pressure and discharged at day 2 and readmitted day 3, readmitted 3 days later because her blood pressure checked by the community midwife was again above 180, 110. So her experience was, I'd had amazing care up until the point of delivery, and then she felt like she was forgotten about afterwards. She felt like care was disjointed with no one person overseeing it. She thought she was sent home with a whole cocktail of drugs and very little idea of what each did and how to titrate and review them. She was told to come to the day assessment unit after going home on the second admission, only to then receive a call the following day to say, we don't see postpartum women and cancelling it, to see the GP, and the GP told her, no, I have no expertise in this, everything should be by the hospital. So you can kind of see where patients are frustrated, and this is not a one-off scenario, sadly. When she was seen, a different doctor saw her weekly, and she got very little consistency of care. The whole thing felt chaotic, with different people suggesting different doses and different orders. So let's just have a quick look at the guidelines, which we've obviously touched on a bit today, largely developed from the NICE guidelines driven by Lucy and amongst others on the call. So they say if you've had a hypertensive pregnancy, you should be discharged home with medication if your blood pressure requires it, using the thresholds we've discussed today. And at 2 weeks and 6 to 8 weeks, you should see the GP for a blood pressure check. And at days 3 to 5 and 7 to 10, the midwife should also be checking the blood pressure. At 3 months, you should be seen in a renal clinic if you have proteinuria at 3 months. And I can tell you, in our own data, I'm going to show you very few people have a urine dip at 3 months. At 6 months, if you still have high blood pressure, you should refer to a specialist clinic. And there are very few specialist clinics and very few cardiologists who have any interest and certainly no expertise in this area of young adult hypertension. So what does the evidence say? Claire's just presented some of her work along with Side Marion, and out of over 30,000 women, only just over 60% actually had a 6-week check at all. In those women who had perhaps the worst phenotype, they had an even lower chance of having a 6-week check, and only just over half had any blood pressure measurement in their records, allowing for the fact that not all BP measurements perhaps were captured in the first 4 to 12 weeks. They were not doing particularly well in the UK, and I think this mirrors what's been said by other speakers around the world. Why is it important? I'm not going to go over this a lot, but we know that it's incredibly common, and perhaps this number of 1 in 10 is now 1 in 8, certainly it is in the US. We know that a third represent with chronic hypertension, and we know that there's a higher risk of not only heart attack, stroke, heart failure, but also valve disease a 5-fold increase in the risk of mitral regurg, and a 3-fold increase in the risk of aortic stenosis. And as we just saw from the last Cochrane meta-analysis, there's no convincing evidence of a lot of one drug over another, allowing for the facts that those trials perhaps couldn't be compared for what Jimmy said. You know, one drug dose was perhaps not a WHO-defined daily dose equivalent of the other. The work that we did in POP was to not really compare one drug to another, but to compare if we actually control the blood pressure a little bit more carefully and actually keep a closer eye through empowering women and telemonitoring them. Can we improve their blood pressure, you know, out to 9 months? And can that alter their potential cardiac trajectory by altering their cardiac remodeling, vascular remodeling? And a paper now accepted in JAMA Neurology to come out later this month, their brain remodeling. And the answer is yes, improving short-term blood pressure has a beneficial impact on all of these things. So blood pressure is lower out at 9 months by 6 millimeters systolic and 6 diastolic and 7 systolic. You get beneficial remodeling. Don't worry about those funny figures. Those are for cardiologists. But it basically means your heart's more efficient, relaxes better. The vasculature is also better. So your central or aortic blood pressure is better, and your aorta is less stiff, and your brain is also less affected. The volumes are greater if you've had self-management and better blood pressure control. So what was the solution? We couldn't see every one of the women that was coming through even our own service. So we thought, let's try and address the worst tip of the iceberg. So we took those with early onset PT and those requiring the most drugs, suggesting they had a more severe form of hypertension postpartum. So we wanted to see these women within the first few months, because we know this is the period of time where we can hopefully make a difference based on the trial data I just showed you. And we're also aligned with what NICE were recommended. So we took those delivered before 34 weeks, those on 3 or more drugs, and asked either the obstetric team or the midwifery team or the GPT to refer in to us. We started it last February, so February 2024, and it's an MDT clinic of cardiologists, obstetric medicine specialists, hypertension specialist nurse, and midwives. The aim was to provide specialist input, identify those at longer high-term risk, and try and, I guess, address that initial clinical concern I showed from the case vignette of trying to give one plan that could be followed for the patient so it felt less chaotic. So 55 women have attended between August, so as far as we've got reviewing the data. The median time to first review is around 12 weeks. Perhaps you can argue this is not soon enough, but women are generally sent home with self-monitoring now in our centre. 50%, however, were still found to be hypertensive based on NICE criteria, NICE NG126 at clinic attendance, i.e. a BP above 135/85 on their home or above 140/90 on the clinic blood pressure on the day. Almost 2/3 required a medication change to bring the blood pressure down, and a quarter were restarted. Ambulatory blood pressure monitoring was performed in just over 1/3, and this has a really good use. A lot of these women have white coat hypertension, and some of them have MAST. And in this particular small case series of 55, 30% had MAST hypertension. We also luckily had the opportunity to perform an echo, and we know from Baschi and Carmen-Chiore's data that, you know, if you have an abnormal echo in this period, your risk of longer-term cardiovascular adverse outcomes and developing hypertension is much higher, and that's the role really for having an echo if you can offer it to the women at this stage. And, you know, it's a low-risk, low-cost test. In these 55 women, there's been no major adverse cardiovascular event, and 1/3 were reclassified as hypertensive following the clinic. And we have set up a long-term follow-up study for not only hypertensive pregnancy, but all women with cardiac complications called FLOWER. And we're using this to recruit into this over a 10-year period. And I'll show you some of the qualitative feedback we've had from the study at the end. How does this compare to what was happening in Oxford before? So we took a comparative cohort of a similar number before the clinic. 15% had special risk follow-up. No blood pressure check was done for 1/3. Only a handful had ambulatory blood pressure monitoring or echo. For those people who were followed up, albeit 3 versus 1, 9% were hospitalized with uncontrolled hypertension, 2 of which had a stroke. This is, remember, in the first 3 years after a hypertensive pregnancy. 3 of these people who've had adverse events had actually been normotensive at the 6-week check, showing the importance that these women are followed at longer term. And only a small number were still on medication, and a lot of them needed to be on medication. So what do patients say about the clinic? Clinic was the first time that I felt I gained any real understanding of the possible long-term impact on my health from preeclampsia, my risk in future pregnancy, and a safe level for my blood pressure. Given the long-term impacts are cardiovascular rather than gynecological, the clinic feels essential, and I cannot overstate how useful I found it. The team that put together this work, including our graduate medical student, Sam Krasner, my DPhil student, Mega Agrawal, an academic F2, George, and our midwife, Yvonne, as well as Paul, and some of the obstetric physicians up in Oxford, Lucy McKillip and Isabella Bertoni, have just published this in Lancet, OG and Women's Health, which I think is a really nice table here, which summarizes all the figures I've shown and discussed in this. We had 100% increase in specialist MDT exposure, 100% increase in pre-pregnancy counselling and discussions around contraception. 100% felt they had the time to ask the questions they wanted to ask. A quarter needed antihypertensive for starting, and 2/3 needed their doses altering. We identified masked hypertension in a large number, and we used echo to guide management. I don't think we can really overstate the importance of this, and I'm aware that this is a clinic running in one centre. Basky happens to run a similar thing in George's, and I know Jenny and Laura do in Manchester, but I really think that these are sort of pockets of clinics running out of people who have a personal interest rather than this being nationwide. And I think, building upon what Lucy said, we really need to take this data, take the evidence from the Cochrane reviews and what else has been discussed today, and it really needs to be rolled out NHS-wide using technology if needs be to make this accessible to all women in the postpartum period. And I'd just like to thank everyone I mentioned on the prior slide. And here's a face to the name, going top left to bottom right, Mega to Paul. George and Isabella didn't give me a photo.
Okay, thank you very much. That's very interesting. I think that to a large extent, you're probably preaching to the converted. I think that to a lot of us, and I suppose I need to sort of give a slight sort of bias here, is that I used to do this in the 1980s, but the problem is that what happened after that is that contracting came in, and then there was no money put in for either pre-pregnancy counselling or this gap between pregnancy and then the need for ongoing care and supervision. And the story you told about the hospital saying it's not our job, and the GP saying it's not my job, and the very few cardiologists interest, it shows you the problem we have. But now with maternal medicine networks, that may increase. So there are no other questions around it. I'm conscious that you've got to rush off, Jamie. So I don't want to hold you back for any longer than we need to. So thank you very much for your presentation, and I look forward to the next year of data and the improvements you've made over that period of time.
Thanks, Jimmy. Thank you. And as you say, this often goes in 30-year cycle. For my colleague I sit with, who's slightly more senior than me, says everything you see comes around in 30 years, and no doubt you were doing it. And I just hopefully now, with the policy changes and the interest of Lucy, we can perhaps seize the moment.
Well, the sad thing I have is that everyone goes on about the hypertension guidelines. The NICE hypertension guidelines were my guidelines from 1980, right down to NARPRO, which is what I recommended in the 1980s. And it's sad that, in fact, that we haven't moved on. So I'm glad there's all these lots of work being done to advance, and for Andy to point out the error of my ways and where the future is going to go. So thank you very much for your presentation. I thank the other presenters from the last session who helped to finish off a wonderful day.